Welcome to this month's edition of our webinar here with Dr. Contreras and Dr. Paulina Larraga. We want to welcome you from wherever you are. We're going to start off in about a few seconds. In the meantime, can you do me a favor in the chat area or in the Q&A? Can you give us your name and give us a shout out of where you're from while we begin our webinar today? Thank you so much. We have Robert from London and Monica from Lynchburg, Virginia. Oh, this is so fast. We have a lot of Ecuador, Eric from San Diego, Angela from Missouri, Raymond from Arkansas, Denny from Arizona, Dr. John from, I lost you. It's going so fast. Kevin from Louisiana. We have so many attendees today, and we're very appreciative of you joining us today. Today's webinar is on a very exciting topic, and it's part of our ImPACT program, our immune personalized autologous cell therapy. It is our lymphocyte, lymphokine activated killer cells. It's going to be specifically about that, but we can discuss many other topics also. We're going to start off with a video explaining what the LAK, so lymphokine activated killer cells are, and then we will begin with a short presentation by Dr. Contreras and Dr. Paulina Larraga, and then we will go to our Q&A session. So we'll start off with that. Thank you so much, and give me one quick second, okay? While it's playing, let us know if everybody can hear it.
At Oasis of Hope, we offer advanced personalized cancer treatments through our ImPACT immunotherapy program, which stands for Immune Personalized Autologous Cell Therapy. The immune system plays a critical role in maintaining cellular health by detecting and responding to pathogens, as well as abnormal or damaged cells. However, cancer cells can evade immune surveillance by exploiting regulatory pathways and masking their presence. LAK cell therapy addresses this challenge by isolating immune cells, primarily natural killer NK cells and cytotoxic T lymphocytes from the patient. These cells are then activated and expanded in our immunotherapy laboratory. The result is an enhanced cytotoxic response, with immune cells better equipped to recognize and destroy tumor cells. This approach strengthens the patient's immune function and offers a targeted method to augment the body's intrinsic anti-cancer activity. The LAK therapy process. The process is safe, relatively simple, and tailored specifically to you. Step 1, blood collection. We begin by drawing a small sample of your blood. Step 2, cell isolation. In our laboratory, we separate out lymphocytes, a group of white blood cells that include natural killer NK cells and cytotoxic T cells, both important for attacking cancer cells. Step 3, activation. Next, we activate these immune cells using specific natural substances called cytokines, particularly interleukin-2. This step dramatically increases their ability to recognize and destroy abnormal cells. Step 4, expansion. We then grow and multiply these activated killer cells in our lab, creating a powerful, personalized immune response. Step 5, reintroduction. Once ready, the cells are returned to your body through a simple infusion. These enhanced cells go to work immediately, seeking out and attacking cancer cells throughout your body. How LAK cells work. Their effectiveness is further enhanced through coordination with dendritic cell therapy, which guide them by presenting precise information about the tumor. Together, they form a targeted and powerful immune response against cancer cells. LAK cells work in 4 main ways. Direct killing. They bind to and destroy cancer cells directly. Signal amplification. They release powerful immune signals that boost your body's overall immune response. Recruitment. They attract other immune cells to join the fight, building a stronger immune presence. Barrier breakdown. Many tumors create protective barriers. LAK cells help break these down, making the cancer more exposed and vulnerable. This multi-layered response makes LAK therapy a powerful tool in our immunotherapy program.
Lymphokine-activated killer cells in coordination with the dendritic cells create a powerful immune attack against malignant cells.
All right, and we're back. Hold on. Sorry about that. All right, and we're back. Thank you so much. Hope you enjoyed the video. With all the excitement, I forgot to introduce myself. My name is Gaston Tesada. I'm the director here at Oasis Hope Hospital. And to my immediate right is Dr. Francisco Contreras, president and surgical oncologist here at Oasis Hope, and our medical director, Dr. Paulina Larraga. So we will start off with Dr. Contreras' presentation, Dr. Paulina's presentation on LAKs. In the meantime, if you want to, after the presentation, we're going to start a Q&A session. So if you want to get a jump ahead and start asking your questions, we're going to have a lot of questions, so we get to as many as we can. But the sooner you submit your question, the easier it is to get to it. So I'll leave it to you, Dr. Contreras. Thank you so much.
Well, this video is very graphic and explains in layman's terms exactly what the lymphocyte-activated killer cells are. And the way we use this is as a bridge on what the activity of the dendritic vaccine is going to do to activate your immune system against the tumor, because it takes time, whereas the LAKs will start attacking tumor cells and abnormal cells immediately. So it's a 1-2 punch, and it's part of our basic immune protocol from our ImPACT program. I think that the most important thing that I can say, outside from what the video showed, is that there's sometimes confusion. Why are we saying NK cells and other lymphocytes? And it's because basically the natural killer cells are not either B or T cells, and so they're part of the immune system on a class of their own. There are some T cells that are also natural killers, and it's also part of these LAK cells. So if you have any questions about that, please let us know, and I can be a little bit more specific about that. It gets a bit complicated technically, even for me, but we'll try to be as clear as possible on how potent and beneficial these type of therapies are for our patients, and this is a big part of our ImPACT protocol.
Can you tell us a little bit about the history of vaccines and the dendritic cells and the LAKs, how it came about, just to give a little bit more context of why we do the immunotherapy here, the way we do it at Oasis?
Yes. Well, in the 1990s, a scientist, the name right now escapes me, he was Canadian, but came into the United States and was then naturalized American, and did a lot of work in cancer. And he's the one that discovered the dendritic cells. And he called them dendritic because it has these protrusions going out, very similar to branches on a tree. Dendros in Latin means tree. So he's the discoverer of these cells, which are the ones that orchestrate what happens with the immune system. These are believed to be the most important elements of the immune system, even though they destroy nothing. But they are like sentries that will see a foe or an enemy coming into our system, will determine what type of enemy it is, and then they choose the best part or element from the immune system to attack that enemy, that foe. It was discovered that generally cancer patients have a low count of dendritic cells, number one, and secondly, that the dendritic cells are blind to many of these malignant cells, and that's why our immune system will not attack tumors, and so they grow insidiously at first because the immune system does not recognize them as foe, because they originate from normal cells. And then the tumors produce a number of proteins and chemicals that will recruit immune parts or immune suppressive elements to shield themselves from the tumor. And so the discovery of this scientist was enormous because he was able then to explain the difference between our innate immune system, the one we're just born with, and then the other part of the immune system that adapts according to the aggressions that our body will have through life. And so this was the basis for the discovery way back in the 1800s of vaccines. We didn't know exactly how it would work. And so this scientist with his group was able to determine what's called the adaptive part of the immune system and the adoptive side of the immune system. And through manipulation of these cells and expanding them and growing them, we can then make a much more powerful anti-tumor attack that is just very, very targeted and will not affect any part of the normal cell population in our system. So it's just a very elegant and beautiful anti-tumor therapy that poses no side effects to the patient because the patient it's developed from the patient's own blood and the information from that patient. So it's a very, very specific and individualized therapy. Thus the ImPACT name, immune autologous, which means it is from the same patient, personalized cell therapy. That's what ImPACT stands for.
I just want to highlight the importance of LAK, now that is our topic today, because we used to call dendritic cell therapy, and we just focus on dendritic cells.
It's the dendritic cell-based therapy, right? Everything stems from dendritic, but not everything. The NK cells don't stem from dendritic cells.
And the LAKs are actually the killer cells. So of course they are going to be guided, but they are the ones that are going to create tumor destruction. So
yes, and so what I meant by the bridge is that when we activate them outside of the body, they need no presentation by the dendritic cells, and so that's how we get the process started. In the meantime, the dendritic cells that have been activated outside of the body are then signaling to the natural killer cells within our system to attack the tumor. And that's what I meant by a 1-2 punch. Well, thank you for that explanation.
Ralph Steinman.
Ralph Steinman.
Yes.
Yes. I'm getting to that age where...
No, you're not. No, you're not.
Apparently I'm on that age already.
Steinman, yes.
I had to Google it, so maybe I'm at that age also,
And you know, something, I think the word is ironic. This guy develops this and he dies one day before he was awarded the Nobel Prize. So the Nobel Prize was awarded post-mortem, posthumously. It's a better word. And he died of cancer. He was not able to use this treatment against his own disease because it was still under development. But he left us with a legacy that opened up immune therapy for oncologists to use, not only in the realm of autologous vaccines, but also for the development of newer anti-tumor agents, or for instance, CAR T cells. The whole base was established by Steinman.
Amazing. So in the process of the LAK development here at Oasis, so patients get to the hospital, we do the blood draw, we separate the dendritic, the LAKs. Are the dendritic cells also cultivated and expanded, or just the LAKs? Because I know
just the LAKs.
We do Neupogen prior so we can increase the amount of white blood?
The amount of white blood
throughout
cells.
The body.
So technically, dendritic cells cannot be expanded. They will not multiply. What we do is we multiply the precursor, which are monocytes. And then once we have this millions of monocytes, they convert into dendritic cells.
Okay.
And so we're able to then bring back millions, between 10 and sometimes 50 million. We've had a couple of patients in the 80 million range, and these then are very active against the tumor. They have their antennas now, and they will guide the natural killer cells basically to attack the tumor. But there are other cells involved in the process, but basically the natural killer cells.
With the Neupogen that we use prior to the extraction, how much more white blood cells are we getting from patients? About 20-30%, or about a couple X, like 3X, right?
Yeah. So before we started using this hormone-like therapy to stimulate the bone marrow to produce more cells, the average count of dendritic cells or monocytes before of dendritic cells that we would apply was 10 million. Now it's at least 20 million.
Wow.
And in most cases, it's close to 40 million. So it was a good idea that I had by trying this method.
Is it the more the better, or is it the quality of the?
Well, both things. Okay. Both things are important, but numbers.
Numbers online. Yeah. Numbers online.
And so the more you have, the better. And we are sure that the quality of the product is very good. We have several methods in the laboratory to characterize, meaning that we know that for sure it's a monocyte, because a lot of times people say, well, I believe there's monocytes there, and I'm going to expand them and then do it. And then we identify them, and then we characterize them because, for instance, the dendritic cells are part of a cluster first of cells, and we're able to activate them and get them to a different cluster, evolve into a different cluster that's really active. And we're able to measure that with toys that we have in the laboratory.
Amazing. The innovation that we've seen since we started doing since we launched our Immuno Lab here, it's been something.
Yes.
Yeah, it's been something good. Something good. All right. So we're gonna get to the Q&A, and we have already like 100 questions. And I really thank you for that, everyone. And we're gonna start off with, I think I know Yuri. I know Yuri, you were here last week. How long do LAK cells work in the body after they are injected?
So every cell in our body has a different lifespan. So for instance, red blood cells in general live 120 days. There are some white cells that live only a couple of days, and some of them even less than a day. I would say that on average, the impact of this therapy is going to be around 3 months.
3 months.
And that's why usually at 3 months we revaccinate. But we have some patients where very aggressive tumors are attacking them, and then we vaccinate every month. Every month,
yeah.
There are protocols in animals where they vaccinate them every 3 weeks, because the lifespan of some of the cells is just very short. Yes, but they do have a lifespan.
Okay.
And then that's it.
Yuri, that was a great question, actually.
I want to add something, because even though, the cells have a lifespan, we also have a memory, and that's something that is very important. So, for example, when we want to detect if a patient had a disease, we can actually take some antibodies to see if the person have, for example, salmonella or a type of bacteria specific. The same here, because we are inducing a memory to the body, so we will have this protection that even though the cells are not active or are not alive, we do have that memory that will maintain in the body.
That is correct. This is a very complicated issue, but in layman terms, we do create every time a memory.
A memory.
Some of you, if you're a little bit more informed, will say, well, I'm not sure because dendritic cells are not the memory. And that's true. The dendritic cells don't keep a memory in that sense, but there are many other cells that work together with the dendritic system that will maintain a memory.
Yeah, we will promote the production of B cells.
Exactly.
All right.
B cells.
The production of B cells. Exactly. It's like the CAR T. Those are designed to regenerate.
So the CAR T cells is a completely different thing because they will regenerate and regenerate. That's why generally one application is enough.
So any immune mutation, there's a lot of
They're
NK cells throughout the body.
they're always replicating.
That is, simple when you explain it that way, Dr. Contreras, that's for sure. Valon is asking, I have prostate cancer with metastasized to the skeleton. Now I have a type of bone cancer, stage 4. What do you recommend?
Well, it's not bone cancer, okay? It is prostate cancer that has invaded your bones. So let me try to explain what that means because sometimes it's confusing. If I would take a piece of that bone metastases and look at it in the microscope, I am going to find prostate tissue. Okay, so that is a metastasis. The original tumor is in the prostate, and it went through the bloodstream generally, and it seeded in the bone and started growing in the bone. So it's prostate cancer in the bone, and well, cancer of the prostate is one of the tumors where we have very, very good results. Breast cancer is another one, ovarian cancer, colon cancer. Other tumors are a lot more aggressive and the results are not as spectacular, but they're still very, very good, okay? So you have cancer of the prostate with metastasis to the bone. This is very, very common. And again, we've had very, very good results against prostate cancer.
I'm going to skip to a couple questions it's a similar question, but stage 2 prostate cancer.
So stage 2, well, the stages are from 1 to 4 in all tumors. And so stage 1 is where the tumor is localized in the organ and the tumor is small, 2 centimeters or less. That's what we call stage 1. Then stage 2 is when the tumor is larger than 2 centimeters, or that the tumor is still small, but regional lymph nodes can be invaded. Stage 3 is when the tumor is larger and some lymph nodes are there, or the tumor is small, and outside of the main area or the area where the tumor is, you will find lymph nodes available. Stage 4 is when there are metastases, regardless of the size of the original tumor. So you may have a tumor that is less than 2 centimeters, which is not common, with metastases to the bones or metastases to the liver. That is stage 4. It doesn't matter how big of a tumor load you have, there is no stage 5. So a patient with a little tumor in the prostate with 1 bone metastasis is stage 4, and a patient that has a tumor that is humongous and there are metastases to the brains, to the bones, to the lungs, to everywhere is also stage 4. So it can be a little bit confusing on how we stage things, but in general, the higher the stage, the poorer the prognosis, regardless of the tumor load.
Okay, and for stage 2?
Sorry, but it's very interesting is that before, like long time ago, we used to think that this method by taking circulating tumor cells will not help in early patients.
Okay.
Nowadays, we know that cells can detach from primary tumor, can be flowing around in the bloodstream, and maybe have not developed the tools to invade other organs.
Yes.
That's why in early stages, still we can detect circulating tumor cells and make therapy from blood from patients on early stages.
This is very, very interesting. What Dr. Larraga is saying. The other part of this is that there might be microscopic metastases that we do not have the tools to see. So an X-ray, no matter how good the machine is, will not detect them, but they're there. And so many times we misdiagnose or misstage a patient saying this is stage 1 because we don't see. And so the legal term now is no evidence of disease, whereas before we said the X-ray is clean, the patient has no tumor activity outside of it. But either there are circulating, all patients will have circulating tumor cells. They will either seed in another organ and grow or not. But that's why even in early stages, we offer the therapy because there could be many cells circulating, threatening the possibility of a metastasis, or there's already metastases that we cannot see.
That is interesting. Seed in other organs. That's a good way of putting it. I like that. All right. Any side effects? Barbara is asking. Anonymous actually. Any side effects, negative side effects of the therapy?
So, because all of the ImPACT elements that we can produce are developed from your own cells, there are no side effects. But in order to create these vaccines, there's a number of chemicals that are used and proteins. We wash them as much as possible, but the patients may have some reactions to those chemicals. And they're usually flu-like symptoms, very mild, usually treated with Tylenol. We've had over the last 15 years, one severe case where we needed to use steroids in high amounts to counteract the reaction. But generally, it's very well tolerated and there are no side effects.
All right. This is a good question. Melissa's asking, can you take the LAK alongside standard chemo?
Not at the same time. So, because the chemotherapy basically is going to destroy those cells. So we recommend to do this therapy as consolidation to a chemotherapy protocol that was finished, or to wait until you, depending on how long is the wait between one cycle and the other one. But usually we want to wait for the chemotherapy to be finished. Or when we know that a patient is going to be receiving chemotherapy, then we can do the vaccination prior and actually precondition this patient to protect the immune system from the onslaught of the chemotherapy. And that way the patient can have a better response. So those are the two ways that we can combine chemotherapy and immunotherapy.
Perfect. Audrey, I want to get to your question, Audrey, but I think it's CA2729, that's breast cancer, right?
Yes.
Okay, she is saying that her tumor marker is over 300 and that she's on Faslodex and Letrozole. But before that, she was on Ibrance. So is that normal that it went up so high, changing are those checkpoint inhibitors or are those?
No. Ibrance is not a checkpoint inhibitor. So if I understand the question correctly, you were on Ibrance and your counts went up.
50-80 on Ibrance, and then she
how much?
50-80 on
Ibrance.
Then it went up to over 300 on Faslodex and Letrozole.
Why did they stop the Ibrance is the question. So most likely because it was not working. And so that means that the tumor was very active. And the more active the tumor is, the higher the number is going to be. And so they switched you then to a hormone blocking agent, which is the sequence is is a little bit different from the norm. Usually we would do hormone therapy first and then Ibrance, or a targeted therapy. But it's not unusual. And let me tell you that 300, even though it sounds very ominous to you, we have right now a patient here with about 3,000.
Okay.
And we still think that she can do very well. So hopefully with the hormone therapy, your response is going to be better.
Also, I think that we cannot relate just on a tumor marker,
Yes.
because in some cases, tumor destruction can elevate, or any kind of inflammation that is maybe not even from tumor activity can elevate the tumor marker. So
that's a great point. That's a great point. And the other one is that tumors are live entities that have periods of activity and rest, like us. And so when they're very active, the number is going to go up, and then the same tumor, the same size, will say, I need a break, and the tumor marker can come
Is it
down.
cyclical? Is it just energy?
No, it's I was gonna say, like women. Unpredictable.
Well, that's true. I cannot deny that.
Listen, I have 4 sisters, I have 4 daughters. I know what I'm talking about.
I'm married to one of those, so I know.
Yes. Sorry, I'm getting in trouble here.
No. All right, that was good. Denny's asking, how soon after radiation can I start LAK therapy or ImPACT?
Basically, immediately. Radiation therapy, the day that you finish, it's not going to stop. So usually radiation therapy continues to work on a patient for about 6 weeks. So the ideal time would be about that time. But when we see a very aggressive tumor, we've started immediately after the radiation therapy. And if it's spot radiation where the amount of radiation is low and very localized, we do it in combination, because radiation is not necessarily, even though it has a systemic impact to the immune system, it's not working all over your body. It's a very targeted area that is going to be affected. And so we could actually, sometimes we actually combine it. Ideally, 6 weeks after would be good.
Would be good after radiation.
Yeah, the only way that radiation will really affect us is when we give a lot of radiation in several spots of the bone.
Yes.
Because it will affect the bone marrow. But like with the new techniques, I haven't seen a patient that received an extensive radiation to the bone. So.
Yeah, radiation therapy has evolved very, very, very positively. The amount of radiation that normal tissue receives to date is quite low in comparison to a decade ago.
And very precise, right?
Very precise.
Thank you so much. Dr. John Montalvo is asking, this is more a general question, but I see a lot of questions about this. Is cancer an immune system problem, or is it an immune system problem that becomes a metabolic issue?
That's a great question.
That's a good question.
So cancer is definitely an immune problem. If your immune system is up to par, golfers know what I'm talking about. I don't know much. Unfortunately, yeah. So if your immune system is working 100%, you virtually cannot develop cancer. That's why we all know, the old man that lives a block away that smoked all his life, only ate junk, and is 98 and is a selfie, as a 40-year-old. It's just that he was blessed with an incredible immune system. So the only way that you can get cancer is because your immune system failed. So in that sense, it is an immune problem. And the second part of the question was?
Or is it an immune system problem that becomes a metabolic issue?
Well, yeah, I think it's a circulating thing. I think it always starts with the immune system. I don't think. Well, yes, you can do things in your life to destroy your immune system, and then it becomes a metabolic issue. But again, if your immune system is very, very good, it doesn't matter what you do, your immune system is going to be good. I'll tell you the story of my my mother-in-law. My mother-in-law is 96, right? The last time she drank water was in 1957.
Diet Coke, right?
Since then, just you know it, right?
I know it well.
Her idea of vegetables is French fries.
And
she's just perfect. So I believe
with a good immune system.
Yeah, I believe that even if she stabbed herself, she wouldn't die. So to me, it just begins and ends with the immune system, and that's why immunotherapy is so important. And since 1972 that the war on cancer began until 2005 or so, when the first immunotherapy was developed, the immune therapy was not considered important. And to us, it has been important all along. Even before we had access to these vaccines, we always worked for the immune system as much as we could.
Perfect. All right. We're going to move it along with a follow-up question. This is anonymous. I've done targeted therapies such as Herceptin and Perjeta. Perjeta? Right? What's the difference between these?
Well, they're HER2 inhibitors. And so the original one was Herceptin, and they're not checkpoint inhibitors.
They're not?
No.
Okay.
So these are anti-HER2, and Perjeta is just a newer. Now we have many more, that are HER2 inhibiting agents. And these are for breast cancer patients. It can also be used. There are some stomach cancers that are HER2 positive where you can use anti-HER2 therapies, but it's basically a targeted therapy for patients that have the HER2 mutation. And so the question...
That was it. No, what was the difference between
Perjeta and...
No, not Perjeta and Herceptin. I mean, that form of immunotherapy with...
okay. So just to clarify, Herceptin and Perjeta are not checkpoint inhibitors.
Okay. That was my...
So it's not...
It wasn't in here yet.
It's not immune therapy. It's a targeted therapy.
Okay.
And it can be very effective. It is toxic, but nothing close to chemotherapy.
All right. A lot of questions on cost and time. Cost we cover mostly when you call and go through a recommendation, because everybody's different and all recommendations are personalized and treatment is recommended by a specific doctor, and Dr. Contreras is involved in that. So cost, you can call us. In terms of time, we have different kinds of protocols, usually anywhere from 9 to about 21 days, but just the immunotherapy is about 5 to 9 days, right?
Depending on the protocol, yes.
Yeah, the least 5, maximum is 15 if you're going to do tumor infiltrating lymphocytes or kind of NK therapy, but it all depends on the recommendation.
The average, most of the patients will spend close to 3 weeks.
3 weeks, 16 days. 16 days, about 3 weeks. Exactly. Shorter ones, the shortest one is 9 days, the longest one about 21 days. So it all depends on the recommendation, to be honest with you. But in terms of cost, contact our admissions coordinators. There are two right now on the phones. If you want to call them at 888-500-4673, or you can email us at info@oasisofhope.com, or easiest is just go online, fill out one of our contact forms, and we'll contact you. Let me see. If there's no biopsy, how do you take the dendritic cells? Is it just by circulating tumor cells?
Yes.
Yeah, circulating tumor cells.
Yeah, the dendritic cells are obtained from the blood always.
Yes. Yes. Does it apply to brain cancer?
Yes.
Okay. Do you...
All sorts.
KRAS gene? KRAS.
Well, KRAS is a mutation, okay? And there are some targeted therapies that are designed, like the HER2, the anti-HER2, like Herceptin and Perjeta. There are some targeted therapies designed precisely to address that mutation, and but they're not immune therapies again.
So even like TP53, those are mutations. And
Yes.
targeted therapies are used for that, but not immunotherapy.
Yeah, but
Okay.
now there are immunotherapies
Therapies
that are
for-
targeted, but the mutations are usually PD-1, PDL1, CL4.
CTLA4.
That one. It's good that you see. And those are checkpoint inhibiting agents, and those are immune therapies.
Okay.
So there are targeted therapies that will that are not immunotherapies.
Perfect. Let me see. Angel is asking, can the LAK be used about 1 year after the CAR T in multiple myeloma? Thank you.
Yes.
Yeah. Okay.
I would like to, if you're interested to know a little bit more in why you would need that, because as I mentioned before, the CAR T cells are generating these cells on their own. So if it hasn't been sufficient, I would say yes, it's a very good option.
Okay, specific answer, Feriel is asking, my sister had breast cancer 12 years ago, and a couple years ago it metastasized to her spine and now abdominal layer. She used Xeloda and now on Enhertu. Question is why your approach is not used in the US or Stanford or UCSF.
Okay, so Enhertu is another HER2 inhibiting agent. Is it combined with chemo? No, Enhertu is not, right? Combined with chemo.
Yes, Enhertu is the one that contains
that is
chemo.
okay.
Yes.
So Enhertu is a combination of chemotherapy and a HER2 inhibiting agent like the Perjeta or the HER2. Why is this not in the States? It still boggles my mind because the whole thing was developed in the States. We follow all of the protocols from the States. The way I understand it, and I think I have a pretty good understanding, is that the FDA requires safety. Now, there is no safety in a product that you're going to obtain the cells from one patient and give to that patient, and never is going to be applied to somebody else. So that's why the Mexican government opened the door, because it's effective and we do not need safety. Why are they still waiting for safetiness in the States? Because they want to convert this into a drug rather than a personalized therapy. What do I mean by that? They want to create a vaccine for cancer of the breast. Mm-hmm. Right? So now they make it in the lab and they put it in a bottle, and you come and you receive that. They don't take your blood. It has nothing to do with you or your tumor. And that's going to take a long, long time. And that's why it is still not available in the States, because the industry is not interested in individualized therapies that are complicated, expensive, but they make no money.
Yeah, that's what we cover.
It's not rentable. No, in Spanish we say rentable. In English is.
I'm not thinking Spanish also. It's not good business. It's not good business.
The cost effective, yeah.
Cost effective. There you go.
Also, I remember that 8 years ago, when we talk about checkpoint inhibitors, all of them are the fourth line of treatment.
Yes.
Like patients underwent chemotherapy, targeted therapies, and if they failed to all of them, then they went to immunotherapy.
Yeah.
And now we are seeing that
as a first line of therapy.
So yes. I think that,
Yes, this is, gaining experience and the results. The results have been better. And so it just makes sense that if you're going to do immune therapy, we'll do it before chemo.
Before chemotherapy. All right. How about throat cancer?
Which one?
Throat.
Throat cancer.
Throat.
In head and neck cancers, we lump them all together, like tongue, tonsils. And they're aggressive type of malignancies. But with the dendritic cell vaccine, we're having just wonderful results. So yes.
That was for Kelvin. We have a question in Spanish. Gracias. The language of heaven. Gracias por invitarme. No hablo inglés. Les deseo mucho éxito y nunca desistan de seguir trabajando en tu noble misión. Abrazo desde Uruguay. Gracias, Cristina. Y una disculpa que no es en inglés, pero todos. Sorry about that. English is the international language of everything that we do.
Since we have patients from all over the world, what it says here. But we should do one in Spanish.
We should do. Nancy is asking, I finished chemotherapy in June from a molar pregnancy, and just got my port removed. What can I do to prevent HCG hormone return? I did remove my uterus, but kept my ovaries.
Well, for prevention, definitely an ImPACT protocol would be very good.
We are getting a lot of more patients that have kind of that have been through a lot of treatments, have found out and come to us just for the ImPACT program, which is
to reduce the risk of recurrence. Because in most cancers, the rate of recurrence is very high, from 50% upwards. So to reduce that high risk, the ImPACT protocol would be very, very good for you.
Okay. Monica is saying Dr. Ralph Steinman. Thank you, Monica. She got it. She was Googling it for us.
Okay, thank you.
Audrey's asking the cost. Audrey, just call us for the cost. We'll be happy to discuss that with you. Adam is asking, is this treatment used in place of chemotherapy? I think we covered that already, right?
Yeah.
Okay.
Whenever we can, we'll use it instead of.
Okay.
But there are some cases where we have to combine it with.
This is a great question, Sunny. Sunny Goodman. Is there an autoimmune concern if you add NK cells to dendritic cell?
No, not at all. Whereas with targeted immunotherapy, like the ones that we were talking about, the conventional, the possibility of developing autoimmune diseases is there. Not extremely high, but yes. But with the dendritic cell-based therapies, no risk of developing. We've used it now for about 15 years, and we haven't had one case of autoimmune disease caused by our immune therapy.
Yeah, and we have even treat patients with
autoimmune diseases
that
yes.
can flare up or anything.
Yes. And in fact, we're working right now on developing a dendritic cell-based therapy for autoimmune diseases. Very interesting.
All right, Sumaya, this is a great question. Can you clarify if you first need the dendritic cells and then the LAK? And that's a great question, but I'll let him try to answer that.
Here we give them at the same time. You can do one first and the other one later. It doesn't matter. Okay. Generally, we do the dendritic first, but it's in the same day, and then the LAKs.
No, first the LAK and then the dendritic.
I'm sorry.
Yeah.
The LAKs first and then the dendritic.
John is asking, is it GIST or GIST tumor?
GIST
tumor.
Is gastrointestinal stromal tumors.
In my upper stomach. It has been stagnant for 2 years because of my diet and immune system. Can it be treated with this therapy?
Yes, definitely. But you've done really well. It's been stable for 2 years?
2 years, yeah, 2 years.
Wow.
It's been stagnant for 2 years. Stable, stagnant.
What I mean, probably that's what it means. Stagnant is like water that never moves?
Stagnant is like it's in place.
It never moves, right?
It's in place, yeah.
Yeah, well, you're doing great. I probably should hire you. Because 2 years, GIST are generally not very aggressive tumors, but they grow.
They grow, okay.
And they grow very big. Surgery is the best treatment for GIST. But if you're stable and are eating and have no problems, who cares if in 20 years is the same?
Okay, Vanda is asking, how long does it take to grow the cells? How long is the treatment? So to grow the cell is about 3-4 days, right?
It depends on the cell, but in general, the LAKs is 3-4 days. Dendritic cells 3-4 days. So in about 5 days, we have the most basic type of the ImPACT protocol. But there are some cells that need more time. For instance, NKs alone is about 7 days. TILs is about 15 days. Or sometimes even longer. So it depends on the type of cell that you're trying to expand.
Exactly. So let me see success rates. There are a lot of questions on success rates, and let's get into the nitty-gritty, doctor.
Okay, so we're very happy that our results are very good. It's very difficult to do prospective clinical trials, but we've been able to do prospective clinical trials on four different types of tumors: breast cancer, colon cancer, ovarian cancer, and
Lung cancer.
lung.
Yeah.
And we measure them for a small hospital like ours that it's private. It is not possible to do double-blind studies. Why? Because it would be unethical to charge a patient that's receiving the placebo. And if we don't charge them, then everybody's going to know which one is the placebo, and then it's not a blind study. So what is allowed, and it's kosher, scientifically speaking, is that we can develop a group and compare it to a very similar group to the literature. Okay, so that's what we have been able to do. So we get a group of patients with a specific diagnosis. They're all stage 4, and then we compare our stage 4 against
the national cancer averages.
Correct. And so, for instance, in cancer of the breast, where we have our best results, our survival rate, 5-year survival rate, is 3 times more than the norm, than with conventional therapy. Now,
this is stage 4.
Stage 4.
Yeah.
We are treating them. These are patients that received chemotherapy, radiation. So the group that we're getting is the failures of the conventional, right? So they come at a big disadvantage, and still
multiple treated, surgical, post-surgical patients,
post-surgical radiation, chemo,
everything.
And still our 5-year survival rate is 3 times more. When a patient with breast cancer stage 4 comes to us, virgin to treatment, that is, that has not received any chemo or radiation, the survival rate is 5 times. In colon cancer, we only were able to do after therapy. It's just difficult to get large groups of patients homogeneously. And our survival rate is almost 3 times in comparison to the conventional. It's 2 times in colon cancer. In ovarian cancer, it's 3 times. In cancer of the lung, is about 9 times better. But cancer of the lung is so aggressive that in the literature is only 1% that has a 5-year survival rate. Ours is about 9%, but again, the small is our group is very small, and I would say that at least 2 or 3 times better than and a lot of people say, well, if it's only 1%, 2 or 3% is nothing to write home about. For the patient that gets the benefit, it's makes all the difference in the world. So our treatment has been proven to be very successful.
Amazing. We've got so many questions, and the hour is flown by. So we're going to get to about 5-7 more questions. Dr. Contreras' time is very important, but let's continue. Let me see. If you had Epstein-Barr as a child, does that make you more susceptible to cancer?
Yes, I would say so, because Epstein-Barr is an immune suppressing bug, and I think we have noticed. I don't remember. Maybe we should look into the literature. If I remember when I was writing one of my books, that I looked into patients with chronic fatigue syndrome, where Epstein-Barr is a major part of it, that they did have a significantly higher rate of cancer than patients that didn't have it. I don't have the specific data right now in my head, but I would say that because it affects the immune system, it makes you more
susceptible
susceptible,
to
yes.
cancer. I'm getting a lot of questions on cancer stem cells, and I'm grouping a lot of questions because is this effective for cancer stem cells also?
No.
No.
It might be, okay?
Might be.
There are no studies done. The only one that I know, there's a couple of things that are good. We use metformin, we prescribe metformin to our patients because that has been proven to kill stem cells from cancer.
Mhm.
There might be other products that do it, but we don't know.
Okay, Carol is asking, would these work for autoimmune diseases too? And that's a great question, Carol, because we've been trying to
it
develop
is
some-
not designed for that. We are working on producing a dendritic cell-based therapy for autoimmune diseases.
Is that by using T cells or?
No.
Dendritic cells?
So
It's so complicated.
Again, it just gets complicated. So we have a combination of two types of dendritic cells. Ones are called tolerogenic. They tolerate things to happen. And patients with autoimmune diseases have a very low count of this tolerogenic dendritic cells. The non-tolerogenic is the ones that we use, and we sort of, when you produce dendritic cells, when you convert the monocytes,
you choose the.
well, we can't choose it.
Okay.
Both of them are going to be produced, but we tilt the process towards a non-tolerogenic by certain stimulative effects.
Okay.
So if we can tilt the scale for those that we know that we can tilt the scale to the other side. And so we're working on this. It's just that the people at the lab are so busy that we haven't done it yet, but we're trying. But if the question is, if you have autoimmune diseases and you have cancer, can we treat you? Dr. Larraga already said yes. If you have only autoimmune diseases, we're not ready for it.
Okay. Let's see. Is there a limit for vaccine treatments?
No.
No. I mean, can this Yuli is asking, can this immunotherapy help with my stage 1 of endometrial cancer?
Definitely.
Uterus? Yes.
Yes.
Elva's asking, I have brain metastasis, breast cancer. Any recommendations?
Well, because the brain is contained within the skull, any growth or any inflammation that the tumor may have causes major problems. And so we normally will treat those with radiation therapy, either general radiation therapy to the brain or what is called gamma knife, a very targeted therapy for the tumors, and then give the immune therapy to avoid the recurrence.
Okay.
But in most cases, there's no time to wait. And so we have to use radiation therapy, which generally is very effective.
Bill,
And let me just say this. We're always afraid of the damage that radiation can cause to normal cells, correct? The brain cells are the cells that withstand the onslaught of radiation therapy the best in our whole body. So they're the least negatively affected.
Okay. Bill's asking, will this immunotherapy work for all kinds of cancers?
Yes, because it's very specific for that tumor.
Okay.
So regardless of whether it's sarcoma or cancer of the stomach, we will prepare a vaccine for that. There are tumors that respond better than others, right? So we have much better results in cancer of the breast than in cancer of the colon, as I mentioned. Much better results in cancer of the ovary than in cancer of the pancreas, because they're a lot more aggressive. And we're always working on trying to develop more potent vaccines for these type of patients that have more aggressive malignancies.
Okay. love this name, Masi Santini.
Oh, Santini.
Yeah, because our
we have a family member
named Santini. What studies do you require prior to this therapy? Do you recommend PET-CT if you have had mastectomy over stage 1 breast cancer and have had 6 rounds of chemo and am now on letrozole?
Yes, ideally, I'm assuming because it was stage 1 that you are now free of disease or there's no evidence of disease, and this therapy was given to you because you probably didn't. Oh no, she did have a mastectomy, right?
She did have a mastectomy.
So the chemotherapy was to reduce the risk of recurrence, and then the hormone therapy that you're receiving is for the same purpose. So this vaccine would help you to reduce that risk even more, and hopefully in the future stop all conventional therapy.
Okay, she did an update. KI is 67 at 80% and HER2 negative PR.
So it's a very aggressive type of tumor. KI 67 is the test that determines the proliferation rate of cells.
The cancer cells.
And so most tumors are in the range of 10%. 80% is very high. So the risk of this thing attacking you again is very high. And I would highly recommend the vaccine for you.
Okay. Anne's asking, I had colorectal cancer surgery in 2017 with no lymph nodes affected. Follow-ups have been clear. Would I benefit from a preventative aspect?
Yes. Okay. But by now, 2017?
17, yeah. That's 8 years ago.
You're in great shape. So usually after 5 years, the possibility of this thing coming back is low, but it's still there, and it would be beneficial for you. Not urgent, but I think that it would be beneficial for you.
Okay. We're going to do 3 or 4 more
Didn't
questions.
you say that? Oh, well.
That was before it was 5. Now it's after 5. Now it's after 5. I want to get to every question, but I mean, we would need Dr. Contreras to stay here the whole night. Nathan I'm in hospice stage for melanoma that spread all over my body, and I've been fighting this for 14 years. Is it too late for me?
It's never too late. A famous physician whose name I also do not remember.
Somebody put in the notes.
Look it up, please. Said, well, there's life, there's hope.
Yes.
And it's worthwhile trying.
Great. I'm going to lump a lot of questions together. Chronic lymphoma. What do you think?
So in lymphomas, the results with conventional therapy are so good that we recommend conventional therapy. But we do consolidate, as I mentioned before, after the therapy is done and it's effective, to rebuild your immune system, because chemotherapy is going to destroy the immune system, with our ImPACT protocol. I think that it would be very, very good for you.
I don't know if we want to get into this, but a lot of questions on RGCC and the Greek tests.
Our experience was not that positive. We used it for a long, long time, and we did not find a correlation. So the test is to determine what therapy would be the ideal for you, and to which, right? Like which therapies are going to attack the tumor or not, sensitivity. Mm-hmm. And we did not find a good correlation between the things that the test would say. And in many cases, what said that it didn't work would work. So we're not using it. I think there's been new developments. Maybe now it's a little bit better, and I would like to look more into it, because what I'm talking about is 10 years ago.
The RGCC has they developed a lot more tests. So
yeah, so it might be better. Yes, information is always good.
Okay. And the last question by Dr. John, and it's a good question. You're gonna like this question because it's controversial. What if someone's cancer has come back because they took the COVID shots? Will this therapy work?
Yes, of course. We did notice that a lot with our patients the ones that were vaccinated, the tumors came back really very aggressive.
Or that progressed.
Or progressed
Yeah.
when they were doing really good, especially vaccinated. The correlation between when they had COVID or not, I would have to check that. Right? That was not our impression. It was just a vaccinated one. But yes, the therapy would work with.
Because actually most of our patients didn't get sick.
Yeah.
We're very afraid, but no.
Yes.
Mhm.
Before we go,
Yeah,
it just
please.
resonated in my mind what the question about if it's too late for me. And I just want to share that I remember when I entered to work here in your dad's book, I remember that it stated that we can always do something for the patient,
Yes.
even holding hands.
Yes.
Yes.
And for me was like, it blew my mind because it is true. And I think in regarding treatment, everything can be possible, maybe not pursuing maybe remission, but always being stable and the patient can improve quality of life and enjoy life. It's always worth it. So,
Yes.
so yeah, I just want to add that.
Well said, Doctor.
Very nice
Yeah.
comment.
Well, it was there were so many questions we didn't get to, and we do apologize. If we didn't get to your question, please feel free to email us at info@Oasis of Hope Hospital, and we will have one of our doctors answer your questions. Thank you, Doctor. Oh, yes, and we're gonna choose around, how many should we choose today? How many recipients?
20.
20 recipients of today's participants will get an email. And if we signed book by Dr. Contreras, we get an email by tomorrow or the day after, we will send this to you signed by Dr. Contreras. We want to thank you from wherever you are in the world, whether it be the US, Europe, and we've had people from all over the world attend today's webinar. And we want to thank you, Dr. Contreras. Thank you so much for your time. Dr. Larraga, thank you so much for accompanying us on this this month's webinar. Our next webinar is going to be on Lymphocyte.
That's a very interesting.
You want to give a quick? No.
We'll let you.
Yeah, it's the Lymphocyte cell therapy. So it's the third element that we use in our ImPACT program. The first is the dendritic. The second is the lymphocytes, lymphokine. The third is the Lymphocyte. So we're going to go through these, and we're going to have that webinar ready, done in about 2 weeks. Today's webinar will be posted on our Facebook page tomorrow. Kevin, you're going to take care of that, right? Kevin, our systems guy. We'll try to post it on YouTube and everything, but Facebook is very kind because they don't take our stuff off. Yeah, we don't take our stuff off. So on behalf of the Oasis of Hope family, the Contreras family, Dr. Larraga, and the team here at Oasis of Hope, good evening, good morning, good afternoon, wherever you are in the world. Thank you so much for your time and for joining us this afternoon. If you have any questions or if you want to speak to one of our doctors, you can call us at 1-888-500-4673. That's 888-500-4673. Go on our website at oasisofhope.com. Visit our YouTube channel, our Instagram channel, our Facebook channel, or give us a call and we can schedule a free Zoom consultation. All you have to do is send us your medical records or fill out one of our online questionnaires. All consultations are free. They're 45 minutes with one of our doctors. If you're lucky, you might get Dr. Contreras or Dr. Larraga. And we can give you a free personalized treatment plan here at Oasis Hope. Thank you so much again, and God bless you and your family. Goodbye.
Thank you. El culo de los corazones.
Mira, no tenemos bacterias.
¿Qué quiere decir?
De hecho, cuando